Okay, UTH Hub 2, can you hear us? Dr. Kozia, are you there?
Yes, Dr. Mpeta.
All right, Dr. Kandio, are you with us? AIDC.
We are here. That's fine. I'll facilitate that room. That's fine.
Okay. Right. Okay, thank you very much.
Oh, is she there?
No, she isn't.
Okay, it's okay. I'll join that room.
Okay, thank you very much. So good afternoon, ladies and gentlemen, members of the network. I would like to welcome you to the 49th session of our ECHO program. And today we will be discussing skin conditions in HIV. And to help us discuss this is our expert for the day, who happens to be a consultant dermatologist at the University Teaching Hospital, Adult Hospital, and this is Dr. Owen Ngalamika. Before we go into the deliberations of the day, I should mention that today it's very exciting as we'll be trying out something new, and this is where we break out into smaller groups where we shall discuss the case in depth and then come back into the main session, and then we give the recommendation. So I should mention that this is the first time we are doing this, and of course we encourage each one and every one of us to participate. And Madam Nomsa is definitely going to tell us more about how we are going to do this session. But before we call upon Madam Nomsa, I will ask Mr. Kampamba to take us through the recap of last week's discussion, which was on mental health in HIV.
Okay, thank you very much. So last week, as mentioned, we had mental health in HIV, which was an interesting topic, and several points came out. And you would want to know actually that mental health is one of the neglected NCDs that actually has an impact on the treatment outcome. So we see that psychiatric conditions are undertreated in chronic diseases, and the interlinkage between mental health and HIV was brought out, where we see that mental health may actually predispose one to HIV, and that mental health disorders may be as a result, as a direct effect of HIV infection. So we see actually that healthcare providers should be very familiar with common presentations and management of these psychiatric conditions that present in HIV. And providers should also be very familiar with neuropsychiatric effects of the medications that are used, like ARVs in this case, and the drug interactions that may come as a result of the use of ARVs and antipsychotics. Approach to management should also be biopsychosocial, and there is need to include some mental health tools to the HIV guidelines, especially as we see that mental health has been neglected for long. So these mental health tools would be a good way to start. And also we took note of some of the ARVs that may cause psychiatric effects such as DTG. However, these psychiatric effects do not warrant therapy discontinuation because they can easily be tolerated. Thank you so much, Dr. Mpeta.
Thank you very much. So I actually introduced the didactic presenter for the day. I forgot to introduce myself. My name is Dr. Francis Mpeta. So at this point, I will ask Madam Nomsa to take us through the rationale for the breakout sessions and how we're going to do it.
Thank you so much, Dr. Mpeta. Good afternoon, everyone. Like it has been mentioned, my name is Nomsa Siamwanza. I'm part of the HAP team at UTH. So as you can see, the tele-echo mentoring network has expanded. It's a large network, and this is a good thing. We still want to continue to see every one of you connect. But however, we have also seen that there's been a little bit of decrease in terms of people being engaged, because that's one of our major principles of the model. So to actually improve on what we are doing in terms of in terms of session delivery, we are introducing breakout rooms. So the rationale would like to increase level of participation. So when you break out into your rooms, please feel free to interact and participate and be part of the team. But we also want to increase time for patient case discussion, because we also see that this is where there's a lot of interest, and this is one of our methods in terms of imparting knowledge for guided practice. Then the other reason is that we've also seen that because of the large network, some questions are not addressed. We want to time to actually address some of those questions. So how are we going to do it today? At the hub, the host will automatically assign you to a specific room. And when this happens, you will see a dialog box that will invite you and say the host is inviting you to join. And then you will click on that dialog and join into that room. Then you wait until you have everyone that is invited in that room. And in each of the rooms, we have a co-host or a team lead who is going to facilitate the discussions. And this will take about 20 minutes. After 20 minutes, then the host at the hub will close out the breakout rooms. You'll see another dialogue, which is saying return to the main session. You may want to click on the return to the main session, or if you wait for a few seconds, you automatically will find you back into the main session. Thank you so much. Enjoy the session.
Thank you very much, Madam Nomsa, and I hope that the instructions are clear. Like I said, we will be trying this out for the first time, and we'll only get to that part during the discussion of the case. So before we go into that, and I can assure you we'll try to guide you as much as we can, because this is definitely new. We ask everyone to participate, and for those who are joining using their mobile gadgets, please avoid unnecessary movements, because you kind of disturb the attention of other participants. So at this point, I will ask Dr. Ngalamika, who is going to be the expert for the day, to take us through today's didactic session. So Dr. Ngalamika, that's sure.
Yeah, expanded. Okay. So good afternoon, everyone. So today we'll
just a minute. It's not sharing. Okay, Makando, it's not sharing. Saying that it's paused. It's fine now. Okay. can start introducing yourself, Dr. Ngalamika. Sorry? It's Dr. Ngalamika. You can introduce yourself, what you do, and where you're found.
So I'm Dr. Owen Ngalamika. I'm a consultant dermatologist at UTH Adult Hospital, found at Clinic 3 at UTH. I guess most of the introduction has been done by Dr. Mpeta already.
Start from slide 1.
Okay, so we'll be looking at the skin conditions commonly affecting HIV patients.
Again. Okay.
We'll look at the most common. I'm sure there are others that we've left out, but we'll look at the most common ones that we encounter in our practice. So the learning objectives will be to identify common skin conditions, manifestations in HIV patients, and identify how similar appearing skin conditions can be differentiated. And then one of the objectives will be to list the recommended management options for the skin conditions that we'll discuss today. So these are the conditions that we'll look at. Next slide, please. So generally, I would like to start by discussing the approach to diagnosis of skin conditions. So in most instances, diagnosis is usually clear by appearance of lesions. So you can usually make a spot diagnosis. But in some cases, a detailed history and lab investigations, that's a detailed history and examination plus lab investigations are required to arrive at a diagnosis. So it's very key to identify the primary lesions. The time the patient may be presenting, the lesions may have evolved over time due to scratching if the lesions are itchy or other factors like infection setting in or other, So the time they are presenting, they'll present with modified lesions, which are called secondary lesions. So it's very important to get a history of what the first in lesions actually looked like. So the following are important in describing skin lesions. So size of the lesion it's important to describe how big the lesion is. The color of the lesion can also give you a hint to what's the underlying pathophysiology. For instance, if it's hypopigmented or if it's light in color, then you know that, okay, it has to do with melanin production. If it's, so if it's red, maybe there's inflammation and things like that. The shape of the lesion also, it's important to do that when you're getting your physical examination. And then the type of primary or secondary lesions. So like I said, there are primary lesions and then there are secondary lesions. So you need to do that, to record those as you get in your history and your examination. Arrangement as well. They could be, group lesions or just one lesions, and then distribution as well in terms of where they, how extensive they are, if they generalize or localize where they are. That's also important and key because you find that some conditions commonly affect certain parts of the body.
Okay, so we will go into our first 4 questions, and I will encourage that we try to vote as quickly as we can. So the first 4 question is, which of the following is the commonest malignancy in HIV-infected persons in the world? A, cervical cancer, B, Kaposi sarcoma, C, lymphoma, D, leukemia. So we shall be required to vote in the next 1 minute or so. I'll repeat the question. Which one of the following is the commonest malignancy in HIV-infected persons in the world? Is it A, cervical cancer, B, Kaposi sarcoma, C, lymphoma, D, leukemia? Okay, so a number of us have voted, about 70%. We hope that it could have been 100. So we can go to the next poll question. The next poll question reads as follows. Which of the following is false about herpes zoster? Which of the following is false about herpes zoster? A, it's caused by human herpes virus type 3. B, post-herpetic neuralgia is a complication. C, herpetic lesion crosses the midline in presentation. And D, it's a reactivation of chicken pox. So again, we have got about a minute, which is 60 seconds. I'll repeat. Which of the following is false about herpes zoster? A, it is caused by human herpes virus type 3. B, post-herpetic neuralgia is a complication. D, the herpetic lesion crosses the midline in presentation. D, it is a reactivation of chicken pox. So I've seen a number who have voted. Please, let's keep those answers coming. We're having less people polling in this one compared to the first one. Is it becoming interesting or harder? Okay, we hope that more people should have polled. We don't know why. We'll go to the last poll question for the day. Poll number 3. The following is true concerning drug skin reaction in HIV-infected individuals. A, all skin rashes in HIV-infected persons are due to drug reactions. B, the offending drug should be changed when a person develops skin rashes. C, the development of grade 4 skin reaction warrants stopping of ART. D, when a patient develops hypersensitivity reaction due to ART, stop the ART and restart the same regimen once the reaction is successfully treated. So we can poll as well. We've got 60 seconds. I'll repeat the question. The following is true concerning drug skin reactions in HIV-infected individuals. A, skin rashes in HIV-infected patients are due to drug reactions. B, the offending drug should be changed when a person develops skin rashes. C, the development of grade 4 skin reactions warrant stopping of ART. D, when a patient develops hypersensitivity reaction due to ART, stop the ART and restart the same regimen once the reaction is successfully treated. So we have about 40 seconds. Okay, thank you very much. We will get back to Dr. Ngalamika's presentation and we'll get back to the poll at the end.
So we'll begin with Kaposi sarcoma, which is it's a vascular malignancy. So it's an angioproliferative malignancy, which is caused by human herpes virus type 8, also known as Kaposi sarcoma-associated herpes virus. It affects both HIV positive and HIV negative individuals, but it's more common among the HIV infected. It's the most common HIV-associated malignancy. and it's an HIV stage 4 disease. So at presentation, usually the CD4 counts will be low, HIV virals will be high. It affects more males than females. So that's like clinical features of KS would be, depending on the tone of the skin, they may be brown, reddish or purplish, macules or patches. So these are flat lesions. Macules and patches are flat lesions. Papules or plaques, which are raised lesions, but different sizes, of course, and or nodules. So like if it's a very light-skinned individual, they'll appear purplish. If it's dark, they'll look brownish. The lesions are usually not itchy or painful, so most of the time the patient will start with one lesion, they keep on developing, and they may not seek medical attention because the lesions are usually asymptomatic. The patient may present with lymphedema or woody heart edema, most of the time affecting the lower extremities. KS can also affect internal organs, mostly the lungs and GIT. Can also affect conjunctiva, lymph nodes, and mucosal membranes such as the mouth, like on the hard palate. Diagnosis can be clinical. However, his biopsy for histology is recommended if available, because there are other conditions that can present like KS in the HIV-infected population, like bacillary angiomatosis. As for the treatment, ART may be sufficient for early stage KS. So KS patients will have few lesions, and most of these lesions will be flat lesions which will appear brownish or purplish, and there will be few without lymphedema and no visceral involvement. So these patients may respond well to ART alone, with or without radiotherapy. However, most of the time, patients present with advanced KS. In that case, they may need ART plus cancer chemotherapy. And the chemotherapy is usually administered over 6 cycles. The commonly available agents include doxorubicin, bleomycin, vincristine, and paclitaxel. So these are the options you may have depending on your center and what's available. So there's a 3-drug combination of doxorubicin, which is also known as adriamycin, bleomycin, and vincristine, which is given every 3 weeks for a minimum of 6 cycles. So this is known as the ABV regimen. You can also give bleomycin and vincristine every 3 weeks for a minimum of 6 cycles. You can, if you have and it's available, you can give paclitaxel as monotherapy or liposomal doxorubicin as monotherapy, but these are more expensive, so you may not usually readily have these. The other option for very sick patients with very low HB and very ill, we can give vincristine monotherapy weekly until the patients recover if they need blood transfusions. So it can contain the condition as you resuscitate the patient. So that's it up with KS. Eosinophilic folliculitis is a very common condition in HIV patients. Unlike KS, these patients usually have very itchy conditions. So it usually occurs in advanced HIV disease. Etiology is unknown. However, there are many factors that have been associated. For instance, mites infestations and some fungal infections have been associated with development of eosinophilic folliculitis, but the cause is not really known. It's characterized by small, like 2 to 5 millimeter reddish papules with or without pustules, which are centered around hair follicles. So it's a folliculitis, and it usually affects the face, the torso, and the upper limbs. Lesions are usually very itchy, so the patient will be, sometimes it will commence after the patient has started ART, for instance. So when you see a patient presenting with a maculopapular rash, like raised lesions, which are less than 1 centimeter, reddish, very itchy, HIV advanced disease, think of eosinophilic folliculitis. It's also known as papular pruritic eruption. Treatment will be obviously commencing ART for those who are not on ART. Topical steroids are very helpful. Antiemetics like permethrin cream because of the mite infestations, and antifungals have also been found to be useful. So you need to assess that particular patient, and if ART doesn't work, then try them on the alternative treatment. Herpes zoster, I'm sure most of us have encountered herpes zoster. It's caused by varicella zoster virus. It's also known as human herpes virus type 3. The primary infection with herpes zoster results in chicken pox. And chicken pox may be more severe in the HIV population. This infection results in viral latency. Like all human herpes viruses, there is no cure or eradication of the virus. So the virus stays in the body for life. So it will stay in the ganglions, and under certain conditions such as HIV immunosuppression, this virus will move along the nerves, it will be reactivated, and then it will cause herpes zoster. So usually the distribution, if we look at the clinical features, they will develop vesicles on an erythematous base. So you can see on the picture there is a base of the erythema. And initially the patient has vesicles like fluid-filled lesions. And then these lesions may get secondarily infected, like we see on the picture, and they form pustules as well. And then the lesions are usually very itchy or painful, and usually the pain or the itchiness precedes the eruption. So before the eruption, they'll be feeling some itch or pain, and then the eruption will set in. And the lesions are usually dermatomal distributed, so they're along a dermatome on one side of the body. Treatment, oral acyclovir, is enough to suppress the viral replication and to contain the condition. If the lesions do not respond to that, you can give IV acyclovir, and the other alternative to acyclovir-resistant virus would be foscarnet. Complications would be postherpetic neuralgia and scarring. So after treatment, patients who have continued itching or actually painful sensation because of the involvement of the nerves. Herpes simplex, I hope that picture is clear enough. So herpes simplex is caused by herpes simplex virus type 1 and 2. Usually it can cause, it's the most frequently involved sites will include around the lips and the genitalia. Around the mouth, it's common in the general population, and usually the cause is HSV type 1, and usually genital HSV is caused by HSV type 2. However, you can find both in either site. Clinical features will be multiple, painful, grouped vesicles on an erythematous base. And when the vesicles rupture, they will leave open areas called erosions, like you can see on the picture there. So also you may have, a patient may have itching or burning sensation before the eruption. Treatment, of course, there is no cure. This herpes simplex virus is a human herpes virus. So HSV1 is human herpes virus type 1. HSV2 is human herpes virus type 2. However, this condition is also very, you can maintain and treat the symptomatic phase. So suppressive and symptomatic therapy is very effective. If the patient has multiple recurrences, so initially you may treat the patient over a course of a week and the lesions will go away, but they may keep coming back to you with recurrent similar rashes. So in that case, you may need to put them on maintenance therapy for a few months. Molluscum contagiosum is caused by a post virus, Molluscum contagiosum virus. It's common in children who are not HIV positive. However, it also is common, it may affect adults who have HIV-induced immunosuppression. In adults, it usually affects the genital area, but it may also affect other sites like the face. Clinical features will be dome-shaped papules with a central umbilication. And then if you poke the lesion, there'll be cheesy material inside the lesion. This material is very infectious. So if you look at the lesions, like even on top, I think you can see the central umbilication. You can see a raised lesion, and you can see like a punctate, like an umbilication on the center. So this is a characteristic lesion of molluscum contagiosum. So it can be that severe in adults who are HIV, who are immunosuppressed. Treatment, of course, ART. Cryotherapy using liquid nitrogen, where you just freeze the lesion and you kill whatever is in there. And then imiquimod cream is also useful. And then curettage, you can actually manually remove these lesions and the patient will be relieved. Warts. So there are many types of warts. Warts are caused by human papillomavirus. There are many types of warts. There are common warts, which usually affect the hands. There are flat warts, and then there are genital warts. So you need to know which type of wart you're dealing with. It may or may not affect how you approach the management of the patient. So warts are common in the general population. However, they may be more extensive in immunosuppressed individuals. So usually you have condyloma acuminata, like warts on the genital areas. You may have in HIV, congenital HIV infection, and individuals usually present with very extensive flat warts. So they'll have these light lesions that appear like hypopigmented. They may be slightly raised or flat, and they'll be the whole body. So in that situation, think of flat warts. Clinical features: indurated keratotic flesh-colored or gray growths, may have finger-like projection. So if you look at the picture at the bottom there, they are like finger-like projection on the lesions. If you look at the top, so at the bottom you have the genital warts. At the top you have the common warts, which are more extensive, which actually appear to be a bit smooth surfaced. Treatment for warts. There are many treatments that are available depending on where you are. Podophyllin can be used, but it has to be administered by the health service provider in a clinical setting. Cryotherapy can be done also in a clinical setting where you actually freeze the lesions. Salicylic acid, and you can cauterize, and then imiquimod cream. And there are other alternative treatments like cantharidin. Depends on what you have that can actually be used to treat the warts. Psoriasis. Psoriasis, it's a condition of epidermal proliferation. So proliferation, extensive turnover of the topmost layer of the skin. So it's more common and more severe in HIV infection. It's characterized by increased epidermal turnover rate. Clinical features will be erythematous or red. You can see the lesion on the right. They are reddish, which are raised lesions. And you can see even from a distance that they appear raised. And they usually have silvery white scaling. So the scaling is the excessive shedding of the cells of the epidermis. So it commonly affects the scalp, extensor surfaces, and it may affect the nails as well, but it can be on other parts of the body. In HIV patients, especially, arthritis may also accompany the presentation. So they'll have a psoriatic arthritis. Treatment will be topical steroids if it's very localized. You can use Cota ointment and shampoo for the scalp. Topical vitamin D creams, localized conditions. But if they are very extensive and they have arthritis, you can add oral methotrexate as well. So eczema, it's common in the general population, but it's also common and more severe in HIV-infected individuals. Clinical features will be in the acute stage, we will find itchy, oozing erythematous patches. And then there will be dry and scaly lesions in the more chronic phase. It usually begins in the first 6 months of life and affects the face and extensors in infants. It affects the flexural areas in children, like on the right side, that's a flexural part of the body. And that looks like a more of a chronic eczema where it's dry and increased skin markings and some scaling as well. In adults, it usually affects the hands, maybe because of exposure to certain irritants and allergens, frequent washing of the hands due to occupational exposure. Treatment will be topical steroids in the acute phase. Emollients are very key for eczema, especially in the winter months when the weather is very dry. And topical calcineurin inhibitors are very important, like tacrolimus. So you can give steroids, but you cannot give steroids for a very long time because they'll have their own local or systemic side effects depending on the extent of application. So you need to factor in the use of steroid-sparing topical immunosuppressive drugs like tacrolimus. And then you can also use antihistamines for itching. Seborrheic dermatitis, it's more common in HIV patients. It's caused by Malassezia fungal species. Clinical features are yellowish greasy scaling on erythematous base, and it commonly affects the scalp. So these are seborrheic areas where there is more sebaceous glands. The scalp, eyebrows, nasolabial folds, and lateral aspects of the nose. Treatment will be topical antifungal creams and antifungal shampoo for the scalp. You can also use topical steroids, mild to medium potency steroid. Fungal infections are also very common in HIV patients. Most common types will be tinea capitis. So tinea capitis will affect the head. However, tinea capitis is quite common in children who are not HIV positive. So it's pretty much a child's condition where adults rarely get tinea capitis. However, if they're HIV infected, they are likely to get it. So there will be erythematous scaling with well-demarcated patches. Tinea corporis will affect the body, and there will be circular or oval raised edge with central clearing, ring lesions. So this is what is typically known as ringworm. So most of the time when you say ringworm, you are referring to a fungal infection, tinea corporis. If you look at the picture at the bottom on the right side, you can see that ring lesion. So it will start in one place, start extending on the sides. It will be clearing on the center as the edge is advancing on the side. So it forms a ring-like pattern. That's why it's called a ringworm. It's not actually a worm infestation. It's actually a fungal infection. Tinea pedis affects the feet. It's called athlete's foot, typically between the toes in warm winter months, usually among athletes or people who wear shoes and don't change socks for long periods of time. So it's also pretty common also in HIV. Tinea cruris in the inguinal areas. And then there is also tinea vesicolor, which may present with hypo or hyperpigmented patches on the body. Like if you look at the bottom left picture. So this fungal infection affects melanin metabolism, which may increase or reduce production of melanin in those parts where it infects and cause those lesions. Tinea unguium, also known as onychomycosis. This is tinea affecting the nails. So the tinea are dermatophytes. Usually dermatophytes feed on keratin. Keratin is found in the nails, in the hair, in the epidermis, top layers of the epidermis of the skin. So those are the sites that will be affected. So the tineas are that, except for tinea vesicolor, which is caused by Malassezia species. That's a different. So drug eruptions are very common in HIV individuals. The following are, these are some of the common drug eruptions in HIV patients that may require admission and or discontinuation of the causative agent. So you have Stevens-Johnson syndrome, toxic epidermal necrolysis. So these two, Stevens-Johnson syndrome, so it's a spectrum of disease. It may start localized, a bullous condition to start with necrotizing areas. It may start as very localized, and it will start extending to involve many parts of the body, and it can evolve to become toxic epidermal necrolysis. And on the right side, so you can see on the left, the first picture there, you can see different spots forming. But on the right, on the middle picture, you can just see sheets of skin peeling off. That's very classic of toxic epidermal necrolysis, regardless of the extent of involvement. On the far right is erythroderma or exfoliative dermatitis. In this one, you'll find that the patient will be on medication, and then they'll start developing a generalized erythema or redness and scaling. So that's exfoliative dermatitis, also known as erythroderma. Other conditions that may warrant stopping the causative agent at admission will be DRESS syndrome, which is a drug rash with the eosinophilia and systemic symptoms. So the patient will have a generalized drug exfoliation and all. They'll have the eosinophilia on your full blood count differential, and they will have other organ involvement like deranged liver function tests, renal function tests. Then the other type of drugs would be like morbilliform drug eruption. But these are key to remember that once a patient develops this, you have to stop the offending agents, including ART or Zeptrin. So WHO has toxicity estimates, which you can refer to the WHO website. I will not go through everything. The main point here is that there are mild reactions which may not necessarily require changing treatment. There are moderate reactions where you can weigh whether to change or not. And then there are severe and life-threatening conditions where you actually need to admit and stop the treatment. So these are some of the key points from today's presentation. Skin conditions are very common among HIV-infected individuals. They may be more severe and more prevalent in HIV patients than the general population. Initiation of ART is an important aspect of managing skin conditions in HIV patients, because most of the time these become worse or are induced by the dysregulation of the immune system and the immunosuppression as well. Then identifying characteristic primary lesions is cardinal in diagnosis of skin conditions. So you need to get a good history. In case you can't make a spot diagnosis, get a good history of how, when it started, and where, and everything else that can help you in arriving at a diagnosis.
Thank you very much, Dr. Ngalamika, for making such a complicated case in HIV so simple. And I think a lot of us have got questions, and probably before we go to the question and answer session, I would like us to go through the poll questions once more. And if we could bring back the poll questions, we'll start with poll number 1. Okay, so the first poll question reads, which of the following is the commonest malignancy in HIV-infected persons in the whole world? So I hope that this time we're going to have 100% voting, because last time we had about only 70%. So which of the following is the commonest malignancy in HIV-infected persons in the whole world? Okay, so we've got about 70% again who have voted. We are ending the poll. Dr. Ngalamika, we've got 6% of the participants saying it's A, 1% saying it's C, and 93% going for B. So what's your on this poll question?
So the most common malignancy in HIV patients definitely sarcoma. So if you look at the general population, that's a different perspective.
Sorry, we are getting a lot of feedback from you. Kindly mute yourself. Thank you very much. You can go ahead.
Yes, so it's Kaposi sarcoma. Kaposi sarcoma is, if you look at sub-Saharan Africa, for instance, it's the #1 HIV-associated malignancy among males, and it's either about #3 among females, and it will affect both males and females. Cervical cancer will only affect females, and it may affect both HIV infected and HIV uninfected. So in the HIV population, KS is the most common.
Thank you very much. So we have it, it's B. I would like to remind persons who have joined using their personal gadgets, J7 Neo, kindly rename so that we know your name. And all those who have got nice gadgets bearing the name iPhone, kindly rename so that we know who you are. Thank you very much. The second question goes like, which of the following is false about herpes zoster? A, it's caused by human herpes virus type 3. B, posthepatic neuralgia is a complication. C, hepatic lesion crosses the midline in presentation. And D, it is reactivation of chickenpox. So far we've seen a number of people voting, we're still waiting. Okay, thank you very much for those who have given it a try. So Dr. Ngalamika will take us through the choices. So we have about the majority going for C, which is just 65%. We still have a number going for A. The question was actually asking which statement is false. Yeah, Dr. Ngalamika.
Yeah, so A, of course, herpes zoster is a result of human herpes virus type 3, also known as varicella zoster virus. So that's true. The second one, we covered that in the presentation, posthepatic neuralgia, where you have constant, continued pain on the affected sites after the lesions have gone. That's also a complication of herpes zoster, so that's true. C, the hepatic lesion crosses the midline presentation. Usually you have a nerve, peripheral nerve supplying, a dermatome, a certain part of the skin, and on one half of the body. The other half you have another nerve, so that one is not true. And D, reactivation of the virus that causes chickenpox.
Okay, so thank you very much. So C is the answer. We go to our last poll, and we shall only give it a few seconds, 30 seconds. So if we can poll very fast. The following is true concerning drug skin reactions in HIV. A, all skin rashes in HIV-infected persons are due to drug reactions. B, the offending drug should be changed when a person develops skin rashes. C, the development of grade 4 skin reactions warrants stopping of ART, and then D, when a patient develops hypersensitivity reaction due to ART, stop the ART and restart the same regimen once the reaction is successfully treated. So we have got only 10 seconds, if we can give it a try. Okay, thank you very much. About only half of us have voted. Dr. Ngalamika, the majority are going for C. Kindly your weights on this.
Yeah, of course, C is correct. So all skin rashes, not all skin rashes are due to drug reactions. As for B, the offending drug should be changed when a person develops skin rashes. So it depends. So if it's a mild reaction, there's no, and then the drug is of necessity, you weigh the risks and benefits, there's no need to change the drug. You can still manage the condition. C, development of grade 4 skin reactions due to maybe ART-induced grade 4 skin eruptions may warrant stopping ART. So that's true. When a patient develops hypersensitivity reactions due to ART, you stop the ART, but you do not need to restart the same drug because they'll develop actually a more severe reaction after that.
Thank you very much. And there we have it. All the polls have been discussed by Dr. Ngalamika. I know Yeta had a question, so I'll give chance to Yeta to ask their question. And then after that, I will also allow Livingston. I've seen Livingston Central Hospital have joined successfully this week. If they could, because I think last week they had a number of questions about the skin reactions, and I think they're so glad. So Yeta, kindly unmute yourself and ask your question, please.
Good afternoon. Dr. Zico responded to our question. It was in line with commencing ART on the same day for someone with advanced case. And our concern was on iris in such patients, but Dr. Zico responded to us.
Okay, just for the sake of the network, kindly re-ask your question.
The question was, should we commence ART on the same day of diagnosis for a patient who's got advanced case?
So the ideal would be to commence the chemo before you commence the ART. However, chemo works pretty fast. Actually, after the first cycle, the patient actually will respond very well. The lesions start going down. So you can commence ART and chemo as long as you commence at the same time. There's no problem.
So in short, there's no need to delay. Livingston Central Hospital, I think probably you had a question, I figured. And it's good to have you. I've seen quite a good turnout there. Livingston. Can we unmute Livingston? Okay, Kazungula, you also had a question. Kindly go ahead, Kazungula. I cannot see Kazungula. Anyone to unmute them? Okay. Kazungula, you can go ahead. I can't unmute them too. Okay, Chilenje, your question, please. We are failing to, if kindly you can unmute from your side. Some of them are giving us a challenge to unmute you from our end. So, Chilenje.
Which one sounds
I have 2 years, Dr. Rupi.
can't get you. Chilenje, kindly try to speak as close to the mic as possible.
Which antifungal folliculitis?
Okay, I think the question is, which antifungal do we use for eosinophilic folliculitis?
So you can use fluconazole. The best would be itraconazole. It's more expensive. A few more adverse effects. You can start with fluconazole for a start and then see how it goes. But I wouldn't use antifungal as to begin with. You would want to use first permethrin cream because the mites are the most common. And then you use topical, steroids, possibly with a combination of a topical antifungal. And then if that fails, then you can use an oral antifungal.
Okay, so thank you very much. I can assure you that it's very difficult to finish the topic on skin conditions in HIV. So if you can bring those questions through the chats. At this moment, I will ask Dr. Kavala to put up his case. I'm sure you are able to share from your end. And what we are going to do is we are going to have the case shared, and then only clarifications shall be asked here in the main session. Then thereafter, we shall go in the breakout sessions as we had indicated earlier on. So Livingston, I can see you've raised your hand, but we'll come back to that and later on. Yes, Dr. Kavala, you may take over.
Good afternoon. Hello, Dr. Mpeta, are you getting us?
Hi, Bill. I think the rest of the network can get you. I'm not sure if the hub has froze. Hi, Bill. I think go ahead with the case. Can you hear me?
Dr. Kavala.
Dr.
Are you able to get us?
Yes, we are. Dr. Kavala, go ahead.
Okay, thank you. So we are presenting a case from Petauke Urban Clinic, and the case will be presented by Emmanuel Chanda. He's a clinical officer at Petauke Urban Clinic. You can go ahead.
All right, Emmanuel, go ahead.
Thank you so much. I start my case.
Yes.
A 35 years female patient enrolled on ART on 16th November 2015. First, she was started on TLE, then later transitioned to TLD on 8th of July 2019. She's married, para 4, all children are tested negative for HIV. LMP was on 15th October 2019 on Depo-Provera. No history of TB. She was not working and not keeping any paste at home, not on any drug apart from TLD before the rash. She presented with rashes, exfoliative lesions affecting the periorbital, the neck, and the elbows with reddening of the underlying skin. No history of fever, itch, or previous skin rash. No history of allergy, normal diet made of local food, no history of alcohol. The physical examination, the height was done, which was 161 centimeters. The weight was also done 52 kgs on initiation. Then later it was 64 kgs. The temperature was taken 36.4, degrees Celsius. The pulse was 72 beats per minute. The respiration, 18. The BP was 134/70. The skin rash from the neck, elbow, and periorbital. The physical exam continues. The vitals, weight, and height. You will see the previous slide. The general appearance. The patient looks stable. The skin lesions described as exfoliative, affecting the periorbital area, the neck, and both elbows. The underlying skin appears reddening without scratching lesions. Extremities are preserved. The limbs are normal. The clinical timeline, the ART regimen was started on 16th of November, TLE, that's when the HIV test was done. On the 16th, the results were reactive, and the client was initiated on ART, that is TLE. The CD4 count was done on the 16th, 11th of 2015. The results were 387 cells per mil. The viral load was taken, date collected 21st of April 2019, sorry. Results received 49 copies per mil. Then transitioned to TLD. The creatinine was done on 23rd of April 2019. The results were 89 micromoles per liter. The AST, the liver function test, was done on 21st of April 2019. The results were 41. So those are the pictures for the client. Those are the lesions in the neck, the elbows, the exfoliative lesions. The treatment which was given, the client was put on betamethasone plus gentamicin for 10 days. The client was taken back to TLE with Blue Seal Vaseline application for 14 days. The client has improved. Question 1. Taking back the client to previous regimen, was it a good action or not? Question 2. What could be this condition? Note, pharmacovigilance forms were submitted.
Okay. Thank you very much, Mr. Emmanuel Chanda, for that case. And I will just try to briefly summarize, and then we can ask all our clarifications in this session. Then we'll go into smaller breakaway sessions. There will be 3 rooms, and don't worry, you will be automatically assigned to a sessional room, and you just have to click join. So this is a 35-year-old woman who is married with 4 children, was diagnosed with HIV in 2015 and initiated on TLE. This patient's baseline CD4 was 387 and had done very well. Her medical history was non-significant with no history of TB, animal exposure. She had no allergies, alcohol, and she had a normal diet. So she was, she presented with an exfoliative rash, which was seen around the neck and the elbows, but nothing on the lower extremities. Then she was changed, this rash started after she was transitioned to TLD, which was in July of this year, of which it followed being suppressive, virological suppression. Viral load was of 89 in April. The question they want to ask, what could this be? This condition And was it a good decision to stop the TLD and back to TLE? So we can have our clarifications on this case, and then we'll go into smaller breakaway sessions. I will allow any clarifications? I should presume that this case is as clear as it can be. So,
hi, we have questions written on the chat box, please. There are a few questions. Specifically, one I asked is we need an entire medication history, including any doses of cotrimoxazole this client ever took. Did we get liver function tests? And I think there was a question that was asked before that I think is really pertinent. We know TL started in July, but we don't know when this rash started.
okay, so Dr. Kavala, the questions we have, I think, coming from the network is, number one, did the patient receive any other medications such as cotrimoxazole or Ceftriaxone? And did the patient receive IPT at the time they started TLD? And for how long was the patient on TLD before the development of the rash? Emmanuel and Dr. Kavala.
Thank you for the questions. This client was, in the file, this client was not started on cotrimoxazole. We just seen the CD4 count was around 384 somewhere there. And IPT, she never been put on IPT up to now. She's not on IPT. And this rash started 2 weeks after transitioning to TLD.
Okay, I hope that is clear. So the rash started 2 weeks after transitioning to TLD.
Yes.
The patient has never been on IPT. What about Ceftriaxone? Sorry,
I didn't see any Ceftriaxone on her file, and I even asked her, she never took Ceftriaxone.
Okay, so the patient has never taken aspirin as well. Nutritional status, I think, any comment on that, although we have seen that the weight increased by over 10 kilos over the past 4 years? But
yes, nutrition-wise, she's okay. She's looking stable, and the weight is around 64, 62. Yeah, I feel from the 52 where she started ART, she has really greatly improved.
All right, thank you very much. And I think on the liver functions, only the AST were done as in the case.
Yes.
So I hope we've gotten all the clarifications. So I will ask that we be ready and be on standby to join the session of breakaways. So kindly join any second from now.
Session questions. You have seen? Yeah. So join.
skin conditions. I think if you remember very well, we had one with eczema, and another one had warts. Then the other client, actually, whom we did not say, under medical clinic, and we are wondering what that kind of rash could be. This client actually had has rash all over the body, and also this rash actually it also affects the palms and the soles of the legs. So we have consulted a number of people actually on this one. I think Dr. Ngongo will shed more light on this one, because this child actually had this rash actually for more than 12 years now. We have tried.
Eric, sorry to cut you. First, let's focus on the case presented. Do you need us to show the lesions again?
Okay, maybe you can show the regions.
Okay, so
maybe I can be talking as you are showing the slides. So,
because of time, we only have a few minutes. I know you are itching to share the conditions that you have. We have here Dr. Ngalamika, and I know Dr. Malumani from Livingstone, I think, should also join this. I hope he's joined. So for now, first, I will shift from you. I will ask other people in the network to tell us their thoughts about what they think that patient who has been presented from Petauke actually presented with. What do we think that rash is? Okay. Sure. Was it a hand from Priscilla? Any thoughts? This is a smaller network, so if we can try to say what we think. Okay, so these are the lesions. What do we think this rash looks like based on what we discussed from the presentation? Jeanette Okoye, please go ahead.
Hi, good afternoon.
Good afternoon.
So I have a couple of thoughts. One is, it reminds me of a rash called pellagra, which is caused by a vitamin B3 or niacin deficiency. And given her weight at the beginning of treatment, I wonder about her nutritional status. And then the second thing that came to mind is a specific drug rash called SD-RIFE, S-D-R-I-F-E. It's a symmetric drug-related intertriginous and flexural exanthem where you get this weepy rash in the folds of the skin. So the neck, the underarms, the antecubital fossa, the groin, etc. So those are the two that came to mind.
So you said pellagra and which one? Sorry, come again.
There's it's called SDRIFE for short, and it stands for symmetric drug-related intertriginous and flexural exanthem. A very long name for just a drug rash that tends to happen in the folds of the skin before generalizing.
All right, thank you very much. Any other thoughts on what we think could be trauma? Choma, you can go ahead and mute yourself. Yes, Choma.
We are still brainstorming.
Please don't create a storm in your brains. Wow. All right. Yes, yes. Any other thoughts from other patients? Okay, I can see two friends there. Livingstone, you can go ahead.
Good afternoon.
Good afternoon.
Are you able to get me?
Yes, although
Okay.
try to move closer to the mic.
All right. This is Jean from Livingstone Central Hospital. This is a very, very interesting case. To me, I would suspect a drug reaction to dolutegravir, in the sense that this reaction started 2 weeks after the client was commenced on TLD. And from what they have given us, the information they have given us, there's been a positive de-challenge, such that the symptoms are improving after withdrawing the TLD. So for me, I think it was a good move. What they need to do is, it's okay, we can withdraw the TLD and continue the client on TLE and investigate more of what could have caused this reaction. Like we would do the causality assessment. Is it really the drug that was consumed? Is it a reaction? Is it a food allergy? Did they take any herbs? And all those things. In pharmacovigilance also, there are some documented adverse drug reactions for certain drugs, but other ADRs, they can only be known when a drug has been consumed in large groups of people. So it could be a rare ADR. For me, I think it was a good move. Thank you.
Thank you very much, Jean from Livingstone. Any other contributions? Lukonga, any thoughts? I know you should be joined with your group there. Any thoughts from Kaoma? It's a room packed with a lot of brains. I hope they are not trying to storm their brains as well there. Any thoughts, even from the hub? You may just tell us if you have got any thoughts about the case. That's the rash of the patient. You can see on the face, around the neck, on the antecubital fossa, and then as shown previously on that.
There are no thoughts for Kaoma?
Yes, sorry, speak up again.
There are no thoughts for Kaoma?
Yes, yes, madam. There are no thoughts.
Yes.
Did you say there are no thoughts or there are thoughts from Kaoma?
There are no thoughts, sir.
Okay, thank you very much. Sumiemba Elvis, please go ahead.
Good afternoon.
Good afternoon.
Yeah, I still concur with the previous contributor. I still feel it must be, or it could be a drug reaction. However, the fact that the patient has had no history of any other, allergic history from other substances doesn't mean they can, or she cannot have an allergic reaction from substances around. So I still feel they need to investigate her, or if possible, they can also involve the dermatologist just to look at her and see the way forward. Thank you.
All right, thank you very much. Okay. I will allow one more. Sorry, is there a hand? Okay, any further thoughts from the hub, please? I know that we have got also a lot of brains here and they have been brainstorming. Yes, from Chainama. Senanga was Chainama.
Senanga HNP.
Yes, please.
Hello?
Go ahead.
Yes, good afternoon.
Good afternoon. Try to speak up.
Okay, our thoughts are similar to the previous the speaker who talked about pellagra. We thought it could be primary pellagra because of maybe the deficiencies in the dietary, knowing that the rashes are actually appearing on the upper side of the body, the face, the neck, and also the hand, the areas which are exposed to sunlight. But also, another thought is on DTG, because also allergic reactions like skin rash are also common in DTG. That's our submission.
So how common are they from Senanga in terms of drug reactions? Just any experience from that? How many patients have you seen from the practice?
Apparently, we haven't actually.
Which character is that? Yes, Senanga, you can go ahead.
Yeah, we were saying like apparently we have seen like more than 5 of them.
You are kind of very faint. Try to come closer to the mic.
Okay. Coming closer to the mic.
Yes, we are able to hear you now.
Yeah, sure. Like apparently,
okay, I think they are still having challenges from
like should be like more than
Hello.
Okay, thank you very much. Although we haven't been able to hear you. Yes.
Hello.
Yes, please go ahead.
Yes, we said there are some clients that are presenting with some rashes whereas on DTG. So currently we have seen some like 5 of such clients with such rash.
5. Is it similar to what we have shown you, or is it showing another pattern?
It's the same pattern where they are appearing on the upper part of the body. The hand,
are they
the
male
neck,
or female? Or both?
Mostly females.
Mostly females. Okay. We will very much appreciate if you could send us any images through the hub and then see how we can follow up these cases together. Thank you very much, Senanga, for sharing that with us. Any other contributions? I'll allow one more before we return back to the main session so that we can hear what other groups have discussed. So far we've got some thoughts on pellagra, which is niacin deficiency, and then others are thinking this is a drug-related reaction to DTG. Others are thinking this is a sun-exposed, drug reaction. And then there's another one, which is, I think this is for dermatologists, not for a person like me. SDRFE, symmetrical drug-related intergenous flexural eruptions. I got it right. Nyaku, you better know that diagnosis. So we still have a lot of thoughts, and then let's see how we can have one last contribution before we return to the main session. What about the brains here? Dr. Thomas, seen anything like that? Okay. Okay. Same one. Did it look like that? Okay. Did you get the pictures? You can go ahead and share what you found.
Okay. Maybe just a reminder to everyone that when you do come across any of these cases, to first of all report to ZAMRA, whether or not you are sure or highly suspicious of the drug that is used. So any reaction, regardless of what you're suspecting, should be reported to ZAMRA, and also to take pictures. And I think what we're seeing is generally women tend to react more, have more drug reactions than men, and especially those who are, I think, above 40 or 50. So it would be also important to get those demographics so that we can also build our own data.
All right, so I hope that was clear about pharmacovigilance. And just Smiemba is asking, how do they get to the hub in case they have got a case to present during ECHO? So we will ask for your details, and then the coordinators will definitely get in touch with you and give you guidance of how to submit a case through ECHO. Thank you very much, Smiemba, for showing that expression of interest. So we should be returning to the main session. There's another one?
It was the move, right? I think we haven't discussed that.
Oh, the what? Oh, Okay, I was only one person I think was spoke about. Was there a need for this patient to stop DTG, and why? Just quickly, any thoughts? Any thoughts?
If I might just ask just one more question, sorry. You know, I feel like the rash, at least reading just a little bit more about SD Rife now, it's a rash that you see in intertriginous areas like you had mentioned. And you know, so far we seem to be only talking about the parts of this woman that's exposed to the outside. But I wonder if anyone asked like that intimate history of if this kind of a rash appears in other areas of her body that we can't see, because then I think that might help us differentiate niacin deficiency from, you know, a specific drug reaction, because if it's in other areas of her body, then maybe less likely to be pellagra, maybe more likely to be drug related. But yeah, just one thought.
Okay, yeah, just to clarify, so the areas that were found was actually the face, around the neck, and the cubital fossa. And then there was nothing on the trunk, apart from the upper neck, and there was nothing on the lower extremities. That's the electro aspect of that. So, Stella.
Once you go to charge.
You know, I thought you were done using it. I'm really glad
Oh,
but don't go away. Don't you have your charger?
Okay, so I believe everyone is back in the main session. So it would be interesting to hear what we have discussed in the other breakaway sessions. So I will start with group, is it 3 where Dr. Kozia was? Dr. Kozia, is that group 3 or 2? Are they back in from group 2?
I was in group 2. I'm back. I think others are also still joining.
We are still on the way.
Yes.
Coming back. Okay, okay, Zico, you may actually help us get started with what you discussed.
Okay, so from the group, some of the issues that were raised was that this could have been caused by DTG, but there were also concerns about whether Depo-Provera could have been responsible for this. Although in our discussion, as we were summarizing, we were getting to the conclusion that when we compare the two, whether Depo or DTG, it looks like more likely that DTG could have been responsible, and it's a drug that's also been implicated in causing drug reactions. Someone brought up an issue of whether this was pellagra, but our response to that was that pellagra is associated with malnutrition, and this patient did not appear to have malnutrition or malnourished, and without addressing any nutritional issues, the patient still went on and kind of had the lesions resolved. Moreover, pellagra has a classic presentation of dermatitis, dementia, diarrhea, and eventually death. But of course, we also know that even in the absence of other findings, with just a few findings, the patient can still have that diagnosis. Other issues that were raised were whether it was wise or whether it was right to actually change the drug. I did not give my comment yet, but from what the group was saying, what the network was saying was that, anyway, it was conflicted. Others were for the idea of changing, but majority thought that it was not good to have changed at that particular time. The reason was that it wasn't very severe. That was the reason from the network. I think in summary, that's what we got. But of course, we also advise that a good history with proper chronology of events is very cardinal in ascertaining what the etiology of a particular skin condition is. And I think that's where I can end for now.
Okay, thank you very much. We can now move to group 3, and that's where Dr. Folosh was, if I'm not mistaken.
Yeah, thank you so much, Dr. Mpeta. I actually facilitated that virtually, so I think that was good. It's the first time I've done that. I think special thanks to our HNPs in Mansa, Margaret, Kazadi. They were really active during the session. What we discussed is quite similar to Dr. Zico, and it was interesting how the team was able to come up with what they thought it was, because they felt there was a time correlation between the change of drug and the appearance of the rash. They definitely felt it was related to the drug, and the new drug was DTG. Interestingly, they pointed out that this rash was in the sun-exposed areas. So they felt it had something to do with the sun. So the options that came up were pellagra and eczema. And as Dr. Zico said, pellagra is related to niacin, vitamin B3 deficiency, and can be brought about by malnutrition, but there are other things. Like, I know a question came up, like, was the patient on TPT? Isoniazid is well known to cause pellagra because it causes B3 deficiency. You don't necessarily have to be malnourished. So pellagra came up, but we asked ourselves, but is DTG known to go through this pathway and cause B3 deficiency? We felt not. So we thought, well, this seems to be something that's sensitive to light and related to drugs. So some sort of photoallergic drug reaction is what we thought. As for the change, everyone thought it was a grade 1. We actually went back to the lecture. Everyone agreed it's a grade 1, but I was overpowered. I was the only one on my side. Everyone felt that it was okay to change her. Some of the reasons that were given were things like, well, she's a woman, those, they are very sensitive when they peel, though she seemed to have healed, but people felt convinced that she should have changed. And also, Margaret said something interesting, which is, well, we don't know if it will become worse. I don't know if Dr. Ngalamika will comment on that later, because our fear is like, oh, it starts off mild. What if it goes and becomes those horrible things it showed? So people felt it was in line with that. Of course, I challenge that with the country is moving away from NNRTIs. So we need to be very careful, but I'm sure they'll advise us. As for the pharmacovigilance reports, we were advised by our pharmacists that it's prudent to always submit pharmacovigilance reports, especially if it's post-marketing, like in our situation where we have DTG and TAF, so we always need to submit them. And I think they agreed with the treatment, but they felt that the patient should have avoided the sun and used a bit of sun protection. Thank you.
Thank you very much, Dr. Foloshi, for that. I don't know here if it will be me or Dr. Candio to say what exactly was. Maybe I give you a chance, then I will definitely.
All right, thank you, Dr. Mpeta. It's interesting to hear from the other rooms. I think, speaking for room 1, we also had a similar line of thought. With regards to what the condition was, we had a couple of differentials, well, 2, 3, so to say. And of course, pellagra was entertained. And despite the fact that she is not malnourished, we still thought it's possible that she could have some micronutrient deficiency. And then we also had another differential, which is SD-RIFE, and that stands for symmetric drug-related intertriginous flexural eruption.
Yes.
So, there was a thought that indeed this could actually be related to the DTG, looking at the fact that the rash appeared 2 weeks after this patient was switched to DTG, and that there was some
unfair advantage.
and that there was some improvement after discontinuing the DTG, and of course with the supportive therapy. And then we also had some inputs from Livingstone, and they suggested that, the switch to, back to TLE was okay, but that the patient probably needs to be investigated more. So we need to get a little bit more history. And I think, like Dr. Zico had said, we really need to know the chronological order of, how things happen. So getting more history and getting more investigations, I think would help the patient. And if we could, we suggested that we link this patient to a dermatologist. And of course, I think we'll hear from our subject matter expert regarding the rash. We also had an interesting note from Senanga, where they say they have actually noted 5 clients who have developed a rash after being started on DTG. They said with a similar distribution, and that most of these clients were actually females. So we were also reminded by our pharmacists that we need to be very active in submitting our pharmacovigilance reports. I don't know if I've left anything else from the rest of the team.
No, basically you haven't. I'm glad that you remembered the SD drive. And I think it's kind of tantalizing, and Dr. Folosh is very excited. Dr. Zika, come and tell us more about this condition. And basically that's what we did. And I think just to wrap up, a lot of people said, this is probably a drug-related, which is actually manifesting in sun-exposed areas. Of course, issues of pellagra came out strongly. Now, like we've been told, pharmacovigilance is very important. Post-marketing, maybe before, during the trials, DTG was never seen to have this. And remember, different populations, maybe in our population, like we have seen from Senanga, and we hope that they do send these pictures of these patients so that we see, is it possible that DTG is causing just, a photosensitive rash, or is it really causing micronutrients to result in pellagra? It's something that we are yet to know. And Zambia could be the first in reporting this. And I think whether we needed to change because for fear of the rash becoming worse, or whether we could have tried to treat it before we could actually say, let's change. I think that's a matter that will allow Dr. Ngalamika to help us with. So I will now take it to Dr. Ngalamika to wrap up today's case of what he thinks these lesions are, and how he would advise that we proceed. Dr. Ngalamika.
Thank you. So this case appears to be, if you look at the patient closely, it's a photo-distributed rash without doubt. And if you look at the history, I think it began like 2 weeks post-commencement of switch from TLE to TLD, right? So I would go for a photoallergic drug eruption. Obviously, drug metabolites are distributed to the skin, and UV radiation kind of converts these to active, activates these, and leads to formation of these antigens, and then the skin, the body develops an immune response. So looking at the duration, the distribution, it's very photo-distributed, and the history, so that's very suggestive of a photoallergy. So you can have a phototoxic or a photoallergic drug eruption. Photoallergic would take a bit of time because you need the immune system to be, sensitized and, initiate that immune reaction. Phototoxic would be almost, within a very short period of time, maybe even within 24 hours. As for pellagra, it's a good differential to consider. We're not going to completely rule that out, but looking at the patient, she seems to be in a very fair nutritional status. She looks very well nourished, and looking at the response to the treatment also, this patient wasn't commenced on B3 or nicotinamide. She was treated with topical steroids, which actually really help to relieve most of, which help to relieve the eruption. Also, in terms of pellagra, patient didn't have other, systemic symptoms of, GI symptoms, and obviously it's not in all cases that they will have GI symptoms and neurological manifestations, but looking at the nutritional status, response to treatment, and other factors, I think that we can put that towards the bottom of the differentials. As to if we are still getting many of these cases and we still need to determine whether we should entertain pellagra, it would be, we should probably do some urine samples to test for, niacin in the urine. I mean, there are metabolites of niacin that will guide us in terms of whether there is deficiency or not. Whether the patient should have been, the drug should have been stopped, I strongly feel no, because obviously the patient was very stable. This is a very localized reaction which responded to topical steroids. Obviously, withdrawal of the agent was also involved, but I mean, looking at the risk and benefit, they'll be on this ART for a very long time. So we can't just switch them every time there is a minor, kind of reaction. We have to, if there is a benefit of TLD over TLE, we should do our best to maintain them on the TLD, especially if they're having like this kind of, I would consider it a minor reaction. We start with the topical steroids and then put the patient on sun protection as well, avoid the sun as they are on this. So actually, in most instances, the minor, mild, and moderate reactions can be desensitized over time. So if the patient is on the drug, the body can adapt. So you just avoid the sun, and over time, yeah. So that's my take.
Thank you very much, Dr. Ngalamika, for that elaborate explanation and dissection of this case. And I think I would like to thank everyone. I think you are all amazing in the breakaway sessions, everything. And I think it was so interesting. We have heard of so many conditions that can arise as a result of, drug reaction. I think let's follow Dr. Folosh and give ourselves a hand. Okay, I know that a number of people, and I think this discussion has really brought out a lot of interest. A number of people have said that they have come across that type, this type of reactions or any type of reactions. I will ask that we send those pictures, but please make sure that you get consent before you transmit those pictures to the hub so that we can actually devise a mechanism of how we are going to follow it up. Like Dr. Ngalamika said, we could actually follow up with urine samples to look, is this really pellagra or is it just something that is coming? So I don't know if people can quickly write this email. This is daviskampamba@gmail.com. If we could send our pictures there, daviskampamba, as in one word, @gmail.com. Please send this to one of our coordinators so that we can have these pictures and see how we can assist in ensuring that we are together in management. So it's all small letters, daviskampamba@gmail.com. And I think before we end the session, Dr. Folosh, I think, has got an announcement quickly, and then we'll come and close the meeting.
Thanks so much, Francis. So yes, we need to send in those pharmacovigilance reports. And as Dr. Ngalamika said, we need to really bear in mind the guidelines. I'm sure you saw from the charts, people are saying they are seeing a lot of this. And he has mentioned over time it will go away. Because remember, the country is trying to move away from the NNRTIs, which is a fragrance for a reason. So we need to be very careful before we go back to TLE. So from Professor Lloyd Mlenga, he says the country is now going into active pharmacovigilance for the new drugs we're introducing, which is dolutegravir and TAF. We'll be looking out for weight changes, hyperglycemia, CNS side defects, and we will also be now looking at fetal outcomes, and we are opening pregnancy registries. While we are going to start at 10 sentinel sites, we expect all facilities to report these. Thank you.
Okay, thank you very much, Dr. Foloshi. So we've been advised.
There's no reason because there are some patients. We only found one patient who was indexed. They were indexed, but they did not tell you.
Vubu, you seem to be agitated. Please share your thought before we close. That was a kind of agitated voice. Thank you very much, though. But you can actually send through any questions, any pictures that you have, or any concerns regarding skin conditions or potential drug reactions to the email that has been shown, and it's also in your chats. So next week, we shall be back again, and we shall definitely go into breakaway sessions so that we can increase participation. And the topic is multi-drug-resistant TB, or commonly known as MDR TB. Thank you very much from me and everyone in the hub. To the rest of the spokes, see you next week.